we're moving into assessment, and we're going to be starting with skull assessment, working on the lower extremities up. First, I'm going to be starting with assessing the asymmetry of the movement, the quality, amplitude, and the rate of the movement, and I'll be placing my hands on the dorsum of the feet, the heels of the foot, the shin of the leg, and the thighs, and then I move up to the ASIS. First, I'm going to place my hands on the dorsum of the foot, assessing for the symmetry of the movement. The symmetry of the movement feels uneven on both legs. However, the left feels restricted and tight. For the quality, the left feels tight and restricted. The right feels dense. The amplitude, they both feels decrease with more movement on the left. And for the rate of the movement, we have 6 to 8 cycles per minute. Now moving on to the heels of the foot. The symmetry of the movement feels uneven. The left feels tight and restricted. The quality of the movement feels tight and restricted on the left, dense on the right. The amplitude, they both feel decreased with more movement on the left. And the rate is 6 to 8 cycles per minute. Now moving on to the shin. The movement on the shin is asymmetrical. Left feels tight and restricted, and the right feels dense. For the quality, left feels tight and restricted, and the right feels dense. The overall amplitude of the shin feels decreased on both sides, with more movement on the left. The rate is 6 to 8 cycles per minute. Moving on to the thighs. The symmetry movement feels uneven. The left feels tight and restricted, and the right feels dense. The quality of the movement feels tight and restricted on the left, the right feeling dense. The amplitude has decreased movement on both sides, more movement on the left. Now moving on to the ASISs. Assessing for the symmetry of the movement. They both feel uneven. Left positions superiorly and feels tight. Assessing the quality of the movement. The left pelvic feels tight and restricted. Assessing the amplitude of the movement. They both feel decreased with more movement on the left. Assessing the rates of the movement. The rate is pretty stable with 6 to 8 cycles per minute. Now moving on to the ribs, the lower ribs. Assessing the symmetry of the movement. They both feel uneven and restricted. More restriction on the left side. Assessing the quality of the movement. The left feels tight, dense, and restricted. Assessing the amplitude of the movement. They both have decreased movement with more movement on the left. And to assess the rate of the movement, they both have 6 to 8 cycles per minute. We are now assessing the shoulder with the skull assessment. And I'm placing my hands on the shoulder with 5 grams of pressure. The symmetry of the movement feels uneven. The left shoulder feels elevated and drawn superiorly, pulling forward. Assessing the quality of the movement. The left fascia feels tight and restricted, while the right feels dense under compensating pattern. Quality of the shoulder movement. The left clavicular and subclavicular of the shoulder feels tight, dense, and restricted, while the right feels under compensating tension. Assessing the amplitude of the movement. They both feel decreased with greater movement on the right. Assessing the rate of the movement. It feels stable with 6 to 8 cycles per minute. Moving on to the skull assessment for the occiput. To Vault Old 1, I'm assessing the tentorium cerebelli, and I'm gently cupping my hand around the temporal bone bilaterally, ensuring the ear of the client sits comfortably between my middle and my ring finger. I'm assessing the horizontal membrane, the tentorium cerebelli, by feeling the lateral expansion of the narrowing of the cranium. The symmetry of the movement feels restricted on the left temporal bone, while the right side moves freely. The quality of the movement feels tight and restricted on the left, while the right feels soft in the tissue. The amplitude of the movement is kind of the crease, like the widening of the movement feels the crease on both sides with greater motion on the right side. Now moving on to Vault O2, I'm assessing the fourth cerebelli and the fourth cerebelli. I'm placing my one hand on the occiput and my other hand on the frontal bone, and I'm assessing the vertical membrane, the falx cerebri, and the falx cerebelli. And I'm just listening to the anterior posterior cam shell, the cam shell motion of the cranium. Assessing the symmetry of the movement, the sagittal motion feels uneven, with the frontal bone feeling slightly drawn and pulled to the left. Assessing the quality of the movement, the tissue surrounding the frontal bone feels dense and compressed, while the occipital connection is relatively smooth. Assessing the amplitude of the movement, the cam shell opening is restricted, which is showing a decreased overall amplitude. Assessing the rates of the movement, the rate is consistent at 6 to 7 cycles per minute. Now moving on to Vault O3, I'm placing my thumb bilaterally on the greater wings of the phenoid bone, and then my hand is cupping around the occiput. I'm assessing for the phenoid basilar sacchondrosis, the SBS joint. And I'm looking for the balanced movement of the greater wings of the phenoid at neutral. Assessing the symmetry of the movement, the right greater wing of the phenoid is resting more cranial than the left, indicating a potential right torsion lesion. Assessing the quality of the movement, the left greater wing feels tight and restricted, while the right greater wing feels dense and held. Assessing the amplitude of the movement, the flexion and extension phase shows a decreased amplitude with very minimal movement available on the left. And assessing the rate of the movement, the rate is stable at 6 to 8 cycles per minute. Clinical impression, I found areas of restriction affecting your body's natural movement, particularly through your pelvic and dural system, including your cranial base. I also found a left-sided pelvic restriction with reduced tissue mobility and compensatory tension throughout your body. These findings may be contributing to the symptoms that you have been experiencing, especially in your lower back and your cranium. For clinical reasoning, this restriction can actually create tension throughout the body, fascia, and dural system. Reducing the body natural motion, and it can contribute to the lower back pain, reduce mobility, and tension headache. My treatment approach will focus on improving mobility, reduce tissue tension, and restoring overall balance throughout your body. And for awareness of contraindication, I have screened you during the assessment for any contraindication that you may have, and that will change my treatment approach during treatment. And I did not identify any condition that will prevent us from using these gentle osteopathic techniques. And throughout the treatment, I'm gonna be monitoring your comfort, making sure that you're responding positively to the techniques and that the technique remains appropriate for you. For awareness of current evidence, The treatment plan I'm recommending is based on osteopathic principles and current teaching in cranial osteopathy. And resources such as Cranial Osteopathy by Torsten Leon and Osteopathy by John Patson supports the use of gentle indirect technique to improve tissue mobility and reduce fascial and dural tension, and also promotes the body's natural and self-regulating and self-healing mechanism. Occipital cranial base release, which is a global treatment. A soft tissue release for the occiput. Hands placed under the occiput to release the C1, which is the atlas, and the occipital bone. So I'm just gradually compressing the occipital bone with 5% pressure towards C1. I'll just wait until I see a release. And that is, yeah, soft tissue release of the occiput. So, and next, I'm just gonna be performing the platform to disengage the C1 from the occiput. So my fingertips are posterior to C1, and my fingers are pointing towards the highs, towards the orbit of the highs, and I'm just creating a lifting platform for the occiput with my palm. So I'm just allowing the weight of the head to move forward as it drops into my palm. Like the weight of the head just drops down into my palm. So that is how I disengage C1 from the occiput. And to decompress the occiput from C1, I'm just going to have my index finger on the transverse processes of C1, while my finger 3, 4, and 5 are in contact with the occiput. So I just have this. Yeah. So these both fingers are just on the transverse process of C1, and then my other fingers are in contact with the occiput. And I'm just going to traction the occiput gently and wait for it to release. And that is how I decompress the occiput from C1. Now moving into the next step, which is, or the next stage, which is to reset the condyles of the occiput. I am just gonna laterally spread the occiput just so I can create a form of elevation to the foramen magnesium. So I'm just spreading out. So I'm gently spreading out the occiput bilaterally. And it's, again, 5 grams of pressure, very gentle. And this technique I cannot do for kids under the age of 12. And my client has also told me he doesn't have any issues with his neck, his shoulder, his trapezius, his TMJs. He doesn't have any recent fracture or tear. So it was an okay treatment for him to get. So that is our occipital base cranial release treatment, which is a global treatment. The pelvic diaphragm release, which is a local treatment. My bottom hand is just going to be cradling the sacrum, while my top hand will be resting on the pelvic until we feel a release in the tissue. I'm going to ask you to put your hand on your stomach, and if you just want to please flex your knee. Good. And I'm going to ask you to rotate. Now place my hand on your sacrum. Great. And now extend your leg. And I'm just going to ask you to show me the tip of your pubic bone. Perfect. Thank you. So my top hand is resting close to the pubic bone, and my thumb is pointing superiorly towards the head of the client. And I'm just connecting to the pelvic diaphragm using 5% pressure. And I follow the tissue to ease to release the superior restricted left pelvic tissues. I feel a spontaneous breath, increased warmth, and the tissue softening into my hands. And that is the treatment for pelvic floor diaphragm release. Mandibular bone release, which is a focal treatment. I'm just going to place my both hands bilaterally on the ramus of the mandible, just on the mandibular fossa. And now I'm going to compress because we're doing a compression of the mandible. So I'm going to compress the mandibles superiorly until I feel the mandible is fully compressed. So what I'm looking for is for the temporal bone to flare into my hands, and then the parental bone to kind of rotate into my hands. And that is the treatment for the compression of the mandible. Now to move into the compression of the mandible, my hands are still in the same position on the ramus of the mandible bilaterally. Now I'm going to decompress gently inferiorly into the ramus or into the mandible until I feel the mandible floating into my hands freely. And I'm going to be adding 10-degree pressure anteriorly, and I lift. I'm just trying to reset the condyles and the discs of the mandible. So once I feel the floating of the mandible into my hands, I let go. And that is the treatment for compression and decompression of the mandible. For the mandibular bone release, no modification was required because my client tolerated the treatment very well. However, if the client presented with acute TMJ inflammation, significant pain, recent trauma, or was unable to tolerate compression and decompression, I would modify the technique by using a more indirect contact or avoiding a more direct mandibular compression altogether. My priority would have been to prioritize the client comfort and safety while achieving our treatment goals. That is the modification I would have done if my client needed modification. To reevaluate the occipital cranial base release, I have my hand placed on the occiput and my fingertip under the cranial base. The tissue feels less restricted with improved cranial mobility and a more balanced motion compared to the initial assessment. This suggests a reduction in the tension throughout the cranial base. To reassess the frontal bone, I can now feel this movement, which indicates the frontal bone tension release. Re-evaluation of the pelvic diaphragm. Okay, I'll have you flex your leg and rotate. Place my hand on the sacrum, and you can extend. Can you please show me the tip of your pubic bone? Thank you. I am now re-evaluating the pelvic diaphragm compared to the initial assessment. The tissue now feels softer with improved mobility and a more balanced movement. Left-sided restriction has reduced, indicating an improvement in the pelvic foundation. And that is the reassessment for the pelvic diaphragm release. And to reevaluate the mandibular bone, I will make contact with the mandibular ramus or the mandibular angle. And I'm just reevaluating the mandibular joints. The joints and the ramus of the mandible feels more balanced with improved mobility on both sides compared to the initial assessment. And overall, the findings indicate a positive response to today's treatment.